Dr. Mirfakhraee, thank you for joining us on MD Newsline podcast. Please introduce yourself to our audience.
Thanks, Esther. Yeah, so I'm Sasan Mirfakhraee. I'm an adult endocrinologist based out of Dallas, and I work in the University of Texas Southwestern Medical Center, where I'm an associate professor.
Great. And you presented some interesting work here at the Endocrine 2025 conference. Please tell me a little bit about what you have been focusing on.
Thank you. Yeah, so basically, we're looking at sort of a different, sort of a newer way of managing people that have adrenal insufficiency. And so for the longest time, people that have adrenal insufficiency, we've really had relatively few treatment modalities for them. And so generally it consists of oral steroids, oral glucocorticoids. And what we found is that while that might work for the majority of people with adrenal insufficiency, there are some that unfortunately just don't feel very well. So they continue to have a lot of the same symptoms that they originally presented with. It might be a little bit improved, but not really to the point where their quality of life is where it needs to be. And so we found that if you basically bypass this oral routes and you manage them with an insulin pump, which is actually infusing the liquid hydrocortisone, then you can really tailor this towards their daily rhythm. You can tailor the dosing a little bit better as well compared to the oral dose. And we've seen some improvements in terms of how they feel, in terms of them not having to go to the ER or the hospital as much. And ultimately, they seem to prefer this rather than their oral steroid dose.
I'm so curious because with the insulin pump, there's so much data that can come out of that. How does that look when it's delivering steroids?
Yeah, that's a really good question because currently using an insulin pump to deliver hydrocortisone, so it is off-label. And there are several studies, about kind of 10 studies that have really looked at using this insulin pump to sort of treat people with adrenal insufficiency. But the problem is that everyone kind of has their own dose. And so each paper has their own settings they go through. Each paper kind of also has a different outcome they look at. Some are based on how the patients feel. Others are specific labs like plasma ACTH values that we're using. And so one thing that we did offer in our paper and with the presentation was a formula that we've used that we found pretty effective in terms of really how to transition people over from the oral dose to the insulin pump. What do those initial settings look like? And then how could you then adjust them in the future based on how people are feeling?
And are these able to be monitored remotely at all, or is it all kind of local?
Yeah, great question. So absolutely. So another big positive here is if you have someone that's taking oral hydrocortisone or some oral steroid, you never really know exactly how much they're taking over the course of the day because they might need to take additional stress doses, etc. If someone's on an insulin pump, then yes, you can download those data remotely. You can see, what's happening over the course of the day. Have they needed to adjust the initial settings that you've just set up? Are there additional doses they're taking? How often are they taking some stress doses? And so we can all pull that through the cloud, essentially, review it, and then get back to the patient and see if other changes need to be made.
That's fascinating. And then as far as mitigating symptoms and just helping patient outcome overall, how did the insulin pump approach compare to the oral? What were some of the things that you found that maybe were a little different or prevented with the patient outcomes through the pump?
Yeah, so very good question. So a few things there. So first, in the people that are taking kind of the oral glucocorticoids, what tends to happen is you get these early peaks of cortisol activity after you take the dose. But then after a few hours, the medication basically disappears. And a lot of things that we've noticed with our patients are, one, starting the day is incredibly hard. And so they'll say getting up, getting out of bed, very difficult. Sometimes they'll have some nausea, they'll feel lightheaded, they'll feel dizzy in the morning. And that's really because that dose they took the afternoon before is completely gone. So in the interim, you can have people take the medication 3 times a day, sometimes even more than that, which can be a challenge, but you're still ending up with the same issues where it really disappears overnight. Those levels are essentially 0 in the morning, and people can have a lot of struggle. They can have struggles later in the day as well. So by using this insulin pump and by having some overnight cortisol being delivered, incredibly effective, by also adjusting the dosing so that they can give themselves additional boluses throughout the day as needed. It really kind of mimics the normal physiology. We found that helpful. And if you ask kind of what are some of those symptoms that get mitigated, really it's a lot of the same things that we see in ordinary people that have adrenal insufficiency. So like the headaches, the nausea, the dizziness, the lightheadedness, the energy. Those are the big things that really tend to improve with this.
So when you were doing this work, what governed which patients that you selected for this cohort, and how can that be applied to see what patients with adrenal insufficiency would benefit the most from this insulin pump approach?
Yeah, so that's something we really need to get better grasp of, like who exactly would benefit from this modality, right? Because the vast majority of people, they do fantastic with the oral steroids. It's really kind of the subset of people that don't, right? And so we don't really understand what makes these people different. The fact that they just don't do as well symptomatically by taking oral hydrocortisone or another oral steroid. But generally, the people that we switch over, they have a few kind of criteria. One is that they remain symptomatic, and a lot of the same adrenal insufficiency symptoms that they had initially. Sometimes they'll get a little bit better, sometimes not all the way better. But what we see is that despite being on the oral steroids, despite being on it like 3 times a day, taking it very consistently, they remain persistently symptomatic. So if that's the case, that's someone that we really look at in terms of first making sure that we're not missing another etiology, like for example depression, sleep apnea, a thyroid issue, anemia, other kind of things that can also contribute to like low energy, mood changes that look like adrenal insufficiency. But then other kind of people are people that are getting in and out of the hospital, that are having adrenal crises, people that we can't really rely on their gut to absorb the medication. So people that have malabsorption issues or motility issues with the colon, people that do shift work, and so they're kind of flipping from days to nights, where it makes it really hard to kind of manage them with oral therapy as well. So those are some of the other kind of groups that we might think about using the pump in.
Interesting. Yeah, I was thinking a bit about that kind of lifestyle thing, and also some of the social determinants of health, maybe people who have less familial support or kind of like a support system to keep them. Were there any risk factors that might have been observed in the use of the insulin pump? And were there any differences in, say, like adrenal crises observed compared to people who received this strategy versus not?
Yeah, so we found that, in terms of differences in ER presentations, kind of hospital days, yes. And so things did improve there. And there are kind of a few reasons we conjecture why that might be the case. So the one is that, if you're taking oral hydrocortisone, commonly you'll have people that have like an upper GI issue, they get nauseated, and they just can't keep the tablets down. And so that's, if you're not getting to the ED fast enough, you're also likely dehydrated. That can really kind of compound the issue and push someone towards an adrenal crisis. If you're giving the hydrocortisone subcutaneously, you don't really rely on that oral track anymore. And so I think people are somewhat protected against some of the issues that really can affect the taking of kind of the oral steroid doses. So I think that might kind of explain what we saw in terms of fewer ED visits, fewer hospitalization days for adrenal crises. In terms of the safety you're asking about, so overall we found it to be quite safe. One concern we always have is that someone that's using an insulin pump to deliver hydrocortisone, if there is an interruption to the delivery of hydrocortisone, it can be hard to tell, because if you're getting insulin through an insulin pump, then you'll have a sensor. The continuous glucose monitor will tell you if the numbers are rising because there's an interruption in the insulin. With this, you really don't get that warning. And so people do have to be very in tune to kind of what's happening symptoms-wise. And if they're developing these adrenal insufficiency symptoms really out of the blue, despite bolusing for it, then that's really a clue that maybe there's an occlusion there. Maybe there's some kinkage that's preventing the hydrocortisone from being delivered. And we always tell them, change it out, remove the set, install a different one at a different site. Always carry oral hydrocortisone with you just as like a stopgap measure. But other than that, the main safety issue we saw was kind of skin infections. And so people would have abscesses. 2 people needed an incision and drainage to kind of address their abscess within the realms of our study.
And how were you adjusting levels for things like stress, illness, or various levels of physical activity, different life moments that aren't necessarily regular throughout the day?
Yeah, and that's so tricky too, right? Because we'll have people that have adrenal insufficiency, they'll run a half marathon and they don't need to make an adjustment in their dose, but they're kind of the rare ones. For others, even taking kind of a brisk walk through the mall might kind of trigger some of those symptoms. And so we sort of leave it up to the patient. We kind of tell them, look back, kind of see what some of these activities are that seem like it makes it more difficult in terms of managing your adrenal insufficiency symptoms. And if you're doing something like that, then about 30 minutes before you can give a bolus. It can be a very small bolus through the pump, because by that time it will have kicked in, and hopefully it'll kind of get you through that activity for the next few hours without you becoming symptomatic. But we tell them that they can essentially repeat this bolus every 4 hours if needed to help address some of these kind of emotional turmoil type situations that can lead to an exacerbation of their adrenal insufficiency symptoms.
So speaking of the patients, what type of training was involved in this? And I know you talked a little bit about what to do if there's maybe not the right amount of steroid being used, but what did the training look like? And I'm also interested in the overall age and demographics of your patients, just to kind of understand how they took to using the insulin pump in this way.
Yeah. So ideally, you have a diabetes educator that's affiliated with your clinic, and they're sort of the ideal person, I think. And in the clinic, when we meet with the people, we will kind of go over, are you sure you want to make this transition? Here's what it encompasses. And if they're pretty eager to proceed, then we'll have them meet with our diabetes educator. And generally by then, the patients have a good idea about what kind of insulin pump they want to pursue, but not always. But our educators will have several of the different commercially available pumps in their clinic. The patients can review those and kind of see what's most in line with their daily routine. And then they basically go through it, right? And so at that point, they'll kind of go over how do you fill the reservoir with the hydrocortisone liquid solution? How do you make adjustments to the basal settings? How are you delivering these at least 2 boluses that you'll do over the course of the day? And they'll also go over kind of troubleshooting issues, because sometimes people will develop adhesive sensitivity. What sort of tricks can you do to kind of make things more manageable for the patients moving forward? And so we have a very good relationship with our diabetes educator, who has really helped to kind of start over 30 of these people with adrenal insufficiency on the pumps. When you asked about some of the demographics, so the average age in our cohort was 43 years of age. The majority, about 80% of our people with adrenal insufficiency that we used pumps with were women, and whites, non-Hispanic, in almost all cases there.
Interesting. How was this in terms of cost effectiveness? Did you see any benefits? I think that I know the answer is probably yes, because things are being used more efficiently, but what did that look like on your end?
Yeah. So I think, when a lot of people think about switching over from the oral hydrocortisone to an insulin pump, they think, well, obviously this is going to be more costly kind of in the short term, using this, durable medical device, having to kind of change out these infusion sets, using the liquid hydrocortisone compared to the oral. And yes, in the short term, absolutely, there's going to be an increase in price, buying the pump and kind of getting all these other supplies. But, moving forward, there's likely some other factors there that I think will be cost savings in the long run. Fewer days in the hospital, fewer times presenting to the ED, for example. That's a big one. But I think the biggest thing is really in terms of kind of getting people back their quality of life, right? So now we're seeing people that previously were, if in their words, kind of stuck at home, really unable to kind of engage with the outside world. Now many are fully employed. They're spending time with family, kind of doing other kind of rewarding activities, able to go to school, kind of getting higher level degrees, et cetera. And so I think that in the long term, if you have someone that's really kind of get back that sense of life, things that they couldn't do before, and also spending less time in the hospital and the ED, I think the cost savings are going to be shown, but that wasn't kind of a part of the analysis that we've looked at, unfortunately.
Are there any other formulations that would do well with the insulin pump?
Probably not. So one of the big benefits of hydrocortisone is it has a short enough half-life, and so you can make adjustments over the course of the day, and then people will see that, right? But if you're using kind of one of the longer-acting glucocorticoids that have much longer half-lives, 24, 36 hours, then there's very little benefit in terms of making these adjustments, kind of fine-tuning it over the course of the day, because really the patients are still going to see any changes you made early on 8, 10, 12, 20 hours later. And so for the purposes of an insulin pump, since you really want to do that kind of hour-to-hour fine-tuning, you want a very short-acting steroid, and the hydrocortisone is going to be the best fit there.
And then what's the next step for this research, and what needs to happen, or what's the next step towards bringing this to widespread clinical application?
Yeah. So one of the tricky things now is that since using an insulin pump to deliver hydrocortisone is currently off-label, it can be difficult to get some of the commercial insurances, some of the payers to pay for it. And so we've had fairly good luck with it, just because there are published data, mostly out of Europe, kind of supporting the use of this hydrocortisone infusion for people with adrenal insufficiency. But sometimes we can't ultimately get this approved. And so I think some of the things that will help with that, obviously, are going to be more data. So we need to have a better sense of what people with adrenal insufficiency really would benefit the most with this technology. The second is using kind of a insulin infusion or an insulin pump to deliver hydrocortisone. We really want to know too, what's going to be kind of the long-term effects in terms of being able to deliver this hydrocortisone subcutaneously? We'll likely be able to use a lower dose of hydrocortisone by doing so because people will absorb it more efficiently. And if that's the case, are we going to see a difference in terms of some of the comorbidities that we'll see in people that are exposed to glucocorticoids for a long time? Like, for example, in terms of weight, in terms of blood pressure, blood sugars, cholesterol panels, bone density, are these other things that we're going to see benefits in kind of long-term as well? And then we really want to get a sense of what's going to be the best settings with the pump, right? Because again, everyone's sort of doing their own thing with this. It would be very nice to have a study that really kind of looks at optimizing these pump settings so that people will have a better idea of what to transition to. Should the dose that we transition to be based on what they're starting off with the oral dose? Should it be really kind of different, calculated based on what their body weight is? We just don't know.
If you were to add capabilities to current insulin pumps to make it more suited for steroid delivery, what would be the capabilities that you would add?
Yeah, so I think it's pretty good at this point in terms of, really all you need is something that's going to deliver a basal rate, something that will allow you to bolus. And so for that purpose, really any insulin pump will do. But I think that if you wanted to make things kind of more convenient on the part of the patients, then, some of the things that we hear about is one, in terms of the reservoir, having something that's going to allow kind of for longer use would be nice. Like some of the, for example, Medtronic has these extended infusion sets that allow you to go 7 days. Again, hasn't really been proven or kind of experimented in people that have adrenal insufficiency, but that would be sort of a nice thing to make things more convenient on the parts of the patients. Also having additional options that maybe that don't have tubing with them, kind of besides kind of the Omnipod formulation, that could be kind of a little bit more convenient too, and people that want to be active and get out there.
So as far as working across specialties, for example, we've talked about some comorbidities too. Are there any gaps that you've observed maybe in either patient education or follow-up, or even utilizing some of the data that you got from the insulin pump while delivering the steroids? What is your ideal view of how providers would work across specialties to utilize this new tool?
Yeah, so we right now have seen that there are relatively few people, endocrinologists, that are prescribing this for people, mainly because it's not really a part of the training. Right. So it wasn't part of my fellowship training. I don't think that really most centers are kind of learning about this. I think part of it is kind of the off-label use, but I think there are other factors there that are in play too. People might view this as, being sort of experimental. Why? I've seen so many people that respond to oral hydrocortisone. What's going on here that someone's not doing well that we have to kind of switch over to this newer technology. And so I think some of the unfamiliarity is part of the issue here. But I think that, ultimately, patients are hearing about it. And so right now, the majority of people that I'm switching over to this modality really come to me because they've seen 2, 3, kind of 4 endocrinologists. They've all made adjustments either to the frequency, meaning that they're going from 2 to 3, sometimes more times a day in terms of taking the oral dose. Sometimes they're taking the oral suspension. Sometimes they're using more potent, kind of longer lasting steroids like the prednisone or prednisolone. And at the end of the day, it's just not getting the job done. And so I think that people are very motivated to kind of seek out an endocrinologist that will kind of align with them and try out this technique. I will say that in people that have diabetes, that are giving themselves 2, 3, 4 injections a day, moving to an insulin pump is going to make things more convenient for them. But in the case of adrenal insufficiency, if you're taking a tablet twice a day and you're switching over to a pump, that's going to make things a lot less convenient. But so many patients are very eager to kind of take this on, mainly because they've been so symptomatic, despite taking what should be a pretty simple dose of hydrocortisone twice daily. And again, it's just not getting the job done. And so I think that I don't want to say shows a level of desperation, but really shows that they're incredibly motivated to kind of pursue something different.
Interesting. So speaking of adrenal insufficiency, is there any research that you saw at the conference here that you're really excited about that might impact your work in general?
Yeah, so I was surprised to see, how many people actually are kind of using this modality now, because I thought that, again, since it's really not part of the training, since it's sort of off-label, it can be difficult to kind of get this approved. I thought very few people would be doing it, but we did have people kind of have a show of hands in the beginning of the talk, and I was impressed by how many people in the room really had taken this on. I saw some posters kind of in the expo as well of other people that have really started to use this technique too. So I think that it's catching on. I think that patient awareness is increasing as well with some of the other kind of social media things that we're seeing now. And so if you haven't tried it before, I think that people are going to start asking you about it. And, even if it's not something that someone might be comfortable to do, at least having a framework of how to approach these patients, I think it would be very helpful.
That sounds great. Thank you so much for your time. It's been a pleasure. And thank you for joining us on MD Newsline.
Thank you, Esther. Pleasure's all mine.